We hear about vaccines every day, but do you know the facts? Welcome to Vax Matters, where we explore the truth behind vaccines. I'm Diane Deaton.
And I'm Dion Guillory.
Hi, Diane Deaton here, and welcome to Vax Matters, where we explore all matters related to vaccines. If you're joining us for the first time, we're covering everything from the first vaccine ever developed to all the new vaccines being created today. Joining me, Dion Guillory.
Hi, Diane. It's great to be with you, as always. You know, it's hard to believe that we've already covered so much information about vaccines, but yet here we are.
Indeed, amazing, isn't it? We've talked about COVID, then covered the long history of vaccines, and today we're going to discuss a sensitive topic, but one that needs to be talked about, and we're the people to do it.
You're right about that, Diane. In today's episode, we're going to take a closer look at minority mistrust of vaccines, specifically, and the U.S. healthcare system in general. And joining us for that discussion is Dr. Shantel Hebert-Magee. Dr. Hebert-Magee joins us from New Orleans as one of our regional medical directors with the Louisiana Office of Public Health. Welcome, Dr. Hebert-Magee. Thank you for being our guest.
Thank you for having me.
Let's get started with it because there's a lot to go through here. What exactly is medical mistrust?
I would say medical mistrust can be defined as a skepticism or wariness of medical personnel, medical institutions, as well as advancements, including vaccines. Medical mistrust is oftentimes rooted or predicated in cultural mistrust, meaning that there are subsets of the population that don't identify with the mainstream majority society and have a distrust. And that can be various people who feel that they are on the fringes. Also, medical mistrust is not just a doubt of the medical system, but it's the belief that this entity or the products that they are trying to administer may actually cause harm and be against one's, best interest. So it's a pretty complicated issue.
And to lay the groundwork, Doctor, we're talking about, unfortunately, certain, like you said, segments of the population or certain communities. Is that right?
Yes. So typically it is our minority population. So whether we're talking about African American, Latinx, Native American, low-wage earners, individuals who have previously been incarcerated, individuals who are undereducated, the homeless population, those who feel that they have been marginalized, who feel more vulnerable, and they just don't identify with mainstream, middle-class, white America. And, because they feel that they are not part of the larger populace, sometimes they don't think that their humanity is valued.
And this didn't just happen overnight. This has been a long time in the history of these folks and these communities.
Yes, indeed. I think, unfortunately, the narrative in this country, particularly in the South, the past has been marred by very painful experiences. And different populations have legacies that have been tarnished because of these painful experiences. So whether we're talking about the Tuskegee experiment, whether we are talking about experimentation upon enslaved individuals, but to speak to, I guess some of our earliest exposure, even when the American colonists, right, the New Englanders were first settling in this country, they had an epidemic of smallpox. And, they were so concerned about the spread. And one of the things that happened is that Cotton Mather, who happened to be a Puritan minister, leader, Harvard graduate, and he was also very keenly interested in medicine, had spoken to one of his slaves and asked him did he knew anything about smallpox. And he says, yes, in my homeland, we would take scrapings from, one of the scabs of someone who was infected. And we'll scrape our skin and get a very mild version of this disease. And so Cotton Mather tried to bring that to the colonists. However, they were so skeptical. They were afraid that the indigenous Native American population, as well as the African population, wanted to eradicate them, that they wanted to remove them from society. So they were very pensive about doing it. And some of the colonists did do it, and they actually survived. And so this brings me to the point, I guess the irony is that today we have minority populations who also feel that vaccines were intended to eradicate those that are unwanted, those that are considered, less than desirable. And that has been one of the most difficult aspects of trying to provide vaccines to the community.
And you mentioned some of the cases you mentioned were some of the reasons why African Americans have medical mistrust, but also Native Americans have a historical medical mistrust in the U.S. government. Can you tell us about that story?
Sure. So there are several incidences, but one of the earliest also happened while we had the American colonies. One of the things that the British loyalists did is that they actually took and gave blankets that had been previously used by soldiers who had smallpox. They gave them to these Native American tribes, causing biological warfare. I mean, literally, they gave them something that was contaminant and that they knew their immune system had never been exposed to, intended to eradicate that population. And even, as recent as the 1970s, there were targeted sterilization programs that were implemented to try to prevent Native American women from procreating so they wouldn't be able to have children. I mean, who do we think has the authority to tell someone that they are less than desirable? But I mean, it's not only African American and Native American populations. This was done to those who were considered feeble-minded, those that were considered disabled, less than desirable, undereducated, rural populations. Fannie Lou Hamer was a civil rights advocate, and she talked about as a child, a young girl, she thought she was having an appendectomy. And it was called a Mississippi appendectomy because they actually removed her uterus. She had a hysterectomy, unbeknownst to her. Yeah. And it wasn't until she got married and started trying to have kids. And, she went to doctors, and ultimately they realized that she did not have a uterus, and her husband left her. And so being bereft of the opportunity to actually have children, and it's not natural, it's not anything that you've done, but someone else made a decision without your knowledge. I mean, these are atrocities that people don't forget, and they imbrue our memory. And the reality is that our medical community has been in denialism for a long time. These are uncomfortable subjects. My grandmother, she would always say, let the past remain in St. Louis number 2. And for those who don't know, St. Louis number 2 is one of the New Orleans cemeteries. So leave the past in the cemetery because sometimes it's too painful. It's re-traumatizing. And this re-traumatization, people can't handle it, and there are triggers. And so I would say for these populations, even though we talk about things that happened in the 1970s and in the 1770s, the vestiges are still here, and there are triggers, and sometimes it's just hard to move forward and not consider the pain that it's caused.
I find it remarkable, as you said, when you were talking just a moment ago, that some of these things happened as recently as 1970. That most of us, that's our lifetime. This isn't something that was back in the history books. And it's just remarkable when you start doing all the research and you find out what's happened. You mentioned Tuskegee. What was that about, Doctor?
So the Tuskegee experiment, actually, it was meant to be a study funded by Julius Rosenwald. So many of us are familiar with the Rosenwald Fund. There are various gymnasiums around the country that have been named after him. He was a philanthropist, and he worked very closely with Booker T. Washington, and he believed in community health care. So he wanted to be engaged in Tuskegee, where they had this preeminent Black institution that was doing a lot of work around agronomy and botany and working with agriculture. And additionally, he also wanted to address some of the ailments, realizing that these rural populations didn't have the same access to healthcare. So this is someone long time ago realizing that our healthcare delivery model was not equitable. But what happened is that all the funding that was supposed to go towards providing medication for individuals who were going to participate in this Tuskegee study was lost because the Great Depression happened, and pretty much all the money was gone. So what happens is that the scientists, right, all the health investigators, the nurses, the doctors, everyone involved say, hey, we can continue with the study and we can just observe the natural course of the disease. And the issue is that penicillin became available, which we knew could cure people of syphilis and stop the progression of the disease and prevent people from dying, prevent people from becoming, where they were no longer able to ambulate or walk, prevent neurosyphilis, where they would become, a type of dementia that would develop. That was able to be prevented with the simple use of penicillin. However, they did not have respect for the humanity of these men that were enrolled, the impact it could have on their families, on their children, on their spouses, because in the name of science, these individuals were considered specimens. They were considered guinea pigs. And that's why people wonder, even now when they go to the doctor's office, do they see me as a person, or do they see me as simply being, a condition? They see me as being a research trial participant. Do they see me as someone that they would respect, someone that they would cherish, someone that they identify with as themselves? And the reality is that many people of different persuasions are concerned when they go to various medical facilities that they will not be seen for who they are and will only be seen as that condition or as that medical record number.
Another one of the cases that a lot of people may not know about, and you can really give us some insight on it, is the one about Henrietta Lacks.
Yeah, so once again, Henrietta Lacks happened to fit many of the demographics that we're talking about. Poor, rural, Black woman, and unfortunately, we know that there are still issues when it comes to Black women's health to this day. And she had been diagnosed with cancer, and unwittingly, tissue samples had been removed from her and used, for numerous years all over the world to advance medical science. And it's wonderful for someone to say that they were able to contribute to advancements in cancer therapeutics and all different types of treatment options. Nonetheless, she never gave permission. They never asked her if they can take samples from her body to use for this purpose.
And her family didn't know about it either, did they? Her family never was aware of
they had no idea. And so, and that's the wariness, right? This suspicion, the concerns that people have is, it's not only that you will harm them, but that is a lack of respect. It's a lack of autonomy. People want to think that they have control. If not over what happens to them in life, at least I have control over my own body, that I haven't been violated. And so, it's not just a violation of trust. It's literally that you have permeated my body and have acquired materials without my permission and have disseminated my cells because they became an immortal cell line, meaning that they were able to, typically when they do cell cultures, they live for a certain period of time and then the cells die. So it's hard to have continuity when you're doing research if the cell line keeps dying. But miraculously, she had this cell line that they were able, given the right nutrients and the right environment, to continue to, replicate. And unfortunately, they never received any proceeds. They never received any acknowledgement. And I mean, it's just unfortunate that there's a complete disregard for her and her family. And but this is not the first time. And I think people are afraid that it would not be the last time. And that's why there continues to be so much hesitancy when it comes to, participating in medical trials. I've had, patients. For years, I worked with industry, with device development in order to improve outcomes for patients. And typically, I worked with early detection devices, meaning that we're trying to detect cancer in individuals early enough that we can prevent them from having a negative outcome. And we had clinical research nurses. They would go and consent patients and ask them, do they want to be in their trial? And occasionally, they would have a minority patient. And they really wanted to get them in the trial so we can have more diversity. And unfortunately, they were reluctant. And so they would ask for me to come into the room. And I would go in and I would introduce myself. And then they would ask me, if I enter this trial, am I going to get the good stuff? Mm-hmm. Now, stuff is not the word that they always used, but they said They wanted to know where they're going to get the product, the medication, the tool that was going to improve their quality of life and possibly prevent their disease from worsening. And I couldn't promise them that because in research we do randomized, double-blinded control trials where neither the researcher nor the participant know which arm of the trial they're in. But why would you want to participate in a trial if your experience in life has always been you have been considered inadequate, you have been oppressed, you have never had opportunities? So if you are finally offered the opportunity, please put me in the arm of the trial that's going to give me the cutting edge technology, or that's going to give me, this medication that may possibly add something more than what you currently give everyone else. No one wants to be relegated to the placebo. And I think for many minorities, they feel that either they are the placebo or they've been given the placebo, meaning that they're just part of the status quo. They're not considered a high-valued individual. And it's hard to have those conversations because, as we've been discussing thus far, there are many layers to this. And we can't just forget about the past. We can't negate the past, and we can't ignore the fact that the injustices are still ongoing.
And it doesn't happen overnight as far as trying to correct a wrong or to do something about a wrong and to have people with a different mindset. It takes time. And as you said, this is going on today in this day and age when you want people to be involved in a trial. It's like, oh gosh, I don't know. It's almost to the point that they would say, well, if it were your choice, doctor, would you do it? And that's why it's so important to talk to a doctor, talk to somebody that you trust.
I completely agree. The reality is that many people don't have a relationship with a primary care provider. With the passage of Medicaid expansion in 2015 in the state of Louisiana, hundreds of thousands of people have enrolled to receive healthcare insurance. That was something that didn't exist for huge segments of our population. Yet their habits haven't changed, even though they now have access to healthcare insurance. They still go to the emergency room. They still go to urgent care centers because that's the relationship that's always existed. And so until you actually forge a relationship with a provider, someone that you trust, it's hard to get people to be receptive to something that's new. It can be undaunting if someone surprises you. So we like what we know. We like to have continuity. We like to have, a routine. I mean, sometimes, I drive to work in the morning and I want to go a set way. And then there's a roadblock, right? And you're like, oh, you're frazzled. I mean, it may only take you 2 minutes longer. Right? But you're completely frazzled because your routine has been disrupted. And so for people who for years, for generations, the only time they go to the doctor is when they have a serious ailment, it's hard to disrupt that routine and tell them to come in for preventive checkups, to tell them to come in and get their colonoscopy, their mammogram, to come and get their pap smear. Because, that may not be something that is considered to be a priority for them at this time because they have more extenuating circumstances. As a kid, I would go with my grandmother to the grocery store. I called her Mama Mare. And I would ask her while we were, walking down the aisles, I would point to different items and I'll say, what's that? And she'll say, that's not for us. And I'll say, okay, walking down the aisle. Well, what about that? And she'll say, no, we don't eat that. So I learned as a child that there are things that are insular to my community and things that are foreign to my community. And the thing she was pointing out was sauerkraut. Like, we don't eat sauerkraut. So we didn't eat pickled cabbage, but yet we ate pickled meat. I mean, that's a staple in red beans and rice in Louisiana. We didn't eat yogurt, but we ate Creole cream cheese. So the point is that there are many communities that are insular, and they're insular in order to protect themselves. And so the same way they may not believe the sauerkraut isn't for them, they may not believe certain music isn't for them, and they may not believe that certain medical advancements aren't for them, such as the COVID vaccine. That wasn't intended for us. So you have to see people where they are. We can't be reductive. We can't negate their experience. And so we have to have these open dialogues and conversations in order to really try to address the issues head on.
Yeah, such a great explanation as to how different people see things and think things, especially for generations, like it can be passed on. And, through our conversation so far, we've talked about African Americans and Native Americans and their distrust with the medical community. Also, those who are Latinx have that same distrust. And, about a quarter of those who are Latinx are undocumented, and they are afraid to get medical care for fear of being reported. Doctor, would you say that this is the biggest obstacle for them with their trust in the U.S. health system, or are there other factors that are here in play too?
I would say that is one of the major obstacles. I think families are afraid that this is a ploy by the government to get them to come out to a community vaccination event, get their information, realize that they are undocumented, and then deport them. I actually had an individual tell me that they were so concerned about coming to the event because the fear of being separated from their family in life was worse than the fear of being separated from their family in death.
Oh, my goodness.
Yes, meaning that they would have rather died from COVID, knowing that, maybe this couldn't have been prevented if a vaccine didn't exist, but they wouldn't want to willingly have gone to an entity or an event and gotten a vaccine, expose their family, and then be sent to a country that may have warfare or may not have, provisions in order for them to survive and never be able to see their family again. They said they couldn't live with themselves. And so they wanted the reassurance that this was not some, devious plan that has been concocted to try to get ICE to show up at a particular location. And for that very reason, we had to have the events at sanctuaries, literally sanctuaries, where people think that they can get asylum, a safe haven, a refugium, where they know that, hey, the church is not going to let them come in and take me. And it's sad that that's where we had to have the majority of our events. We also had them at some of the local grocery stores that they, frequent because they have, particular delicacies or fruits and vegetables that are native to their countries at these locations. But it was important that we have that safe haven. But additionally to concerns about being arrested, detained, and deported, they were also concerned about the cost. So we've always said that the vaccines are free, yet when they show up to the event, typically the provider asks for insurance. And many don't understand that, right? They say, why do you need my insurance if this is free? Well, the insurer gets charged, but the actual, person should not receive a charge. But they were concerned. I mean, many of them are day laborers. They're undocumented, they're wage workers, and someone telling them they have to pay $20 or $30 for a vaccine can be a deterrent, because that can go towards gas or an electricity bill or putting food in the mouths of their kids. So they would walk up and then, they would say, gratis, like, is this free? And we would say, yes. And then when we would ask for the insurance card, they would turn and walk away. So I had to speak with those providers and say, please do not ask for insurance unless it's, absolutely necessary, because this particular population, that may lead them to turn away and not get vaccinated on this date.
And as you said, I'm so sorry to interrupt. As you said, there is that barrier, that comfort. We must respect their comfort level. And there is the language barrier. It's just they don't understand.
Absolutely. And that was one of our biggest issues initially when we were trying to roll out our vaccine delivery model, is that we had to have people that spoke their language, right? And it's not just being proficient in the language. It's, sharing that voice. People want to hear and see people that they identify with, right? You look for the familiar face in the crowd. It's like having your school recital and you're looking for your parents. You're looking for that comfort. And for many of them, it's the clergy members. It's members that, have helped them in various ways. So whether they go to food banks, whether they've gone to, or participated in clothing drives, and seeing that person that you recognize, it provides some sense of comfort, some solace that this is a safe space for me. And we made every concerted effort to try to do that as much as possible in order for them not only to come out, but what would happen is that some will come out pensively, they will observe, then they may get vaccinated, and then 2 hours later they bring a family member or a relative or, the neighbor next door. So, once we gave them that reassurance that this is a safe space, we were able to actually, reach some of those in the population that were on the fence.
And that shows a perfect example of why representation matters.
Absolutely. So, and I think that's one of the gaps or chasms that we have to address. Unfortunately, when it comes to, Native American physicians, it's less than 1%. When it comes to African American physicians, it's between 2 to 3% of all doctors. So, people want to see someone who's in the room that they identify with. Langston Hughes talked about American heartbreak, and he talked about the double consciousness of being, both American and Negro. So if we're talking about being American and Black, American and Latinx, American and foreign born, American and disabled, American and old, or being a gender or a gender or religious minority, there are people who just don't feel safe because they feel that people don't recognize them and accept them for who they are.
What do we do, doctor? It's kind of a conundrum. What do we do?
I think the first thing we need to do is acknowledge the past. Be transparent. Don't try to whitewash, history and say that these things didn't occur or that it's a different time. Also acknowledge that, the issues are still ongoing, that there's a lot of social and political factors that impact a patient's or a client's healthcare and wellness. There are substandard living conditions. There is subpar educational systems that certain communities are relegated to. Certain communities are, over, they have a lot of over policing of those neighborhoods. I mean, the simple fact is that there are neighborhoods within our community that have interstates that are directly above their homes.
Right, run right through them.
Exactly. And so not only we're talking about pollution and debris, I mean, how does that affect your ability to feel, safe walking around your neighborhood? Because there's poor lighting. So you have a sedentary lifestyle. There are neighborhoods that are inundated. I mean, any of us can recognize certain neighborhoods and sort of guess who we think are, the residents in that neighborhood. If there is a Panera Bread, a Trader Joe's, we say, oh, this is probably a nice, swanky part of town. And yet, if we see a bunch of fast food restaurants, all together that have, food that is highly, unhealthy, we know those targeted populations as well. And it's unfortunate because it affects asthma. It affects, people who have COPD, those who have diabetes. And so we have to change, we have to review, we have to revise and enact policies and laws that address health equity. We have to engage community stakeholders that people trust. And then we have to, address the need of a person, not only based upon their condition, but seeing them as an individual. So when someone goes to a doctor's office, right, it could be a podiatrist, and they can ask them, have you gotten your, flu vaccine? They can go and see, their eye doctor, because that may be the only physician that they see. They may never go and see an endocrinologist for their diabetes, but they're going to check on their feet because they got to get to work and you don't want to lose a limb. So we have to realize and catch people where they are, meet them where they are, and look at them in total and not just look at them, for diabetic neuropathy and ask can they feel their toes? Ask them what they feel in their heart. Discuss their issues. And so we need to have a diversity of providers. We need to have providers that are not only culturally competent, but they have humility and they're able to, recognize that maybe they haven't walked in someone's shoes. So don't, underestimate their lived experience. And we have to have stakeholders that are going to ensure that we have all the wraparound services until we're able to get provisions into some of those neighborhoods that desperately need it through laws and policies.
And I think you're so correct when you were saying too, and you just kind of hit the nail on the head, talking about to have the empathy, to have the emotion. You do not exclude anyone's experience, and no one is expendable. No one.
I absolutely agree. I in my training, I would come across patients who still, as I say, they talk that Noah or that South Louisiana Bayou talk. So, and they'd be like, "Eh, Nashia, eh, laba," and so I'd be like, "Eh, laba, come on." And so then, they'll go into talking. And so I have this one patient, and I said, "Why are you here?" And they said, "I can't get the water come out the pipes." And so
it takes a minute. Yeah. Okay.
And so my co-resident said, "Are you a plumber?" And they didn't get that they were saying that they had some urinary issues and older gentlemen, some prostate issues, and so there was some urinary hesitancy that he was experiencing, but. He didn't have the vernacular or the lexicon to be able to, exactly say what was going on with him in medical terminology. But he said it, how he could best explain it. And so you have to be able to, hear a person, identify with their experience, and, just recognize them for who they are. I mean, the reality is that we do have people who come in who are disheveled, people who come in who have behavioral health conditions, individuals that may come in and they have a certain aroma that may, not be the scent that we want to smell, but we don't know what has led that person to be in that condition. And so we are supposed to be that safe haven. We're supposed to be, that community that actually looks beyond the exterior and focus on trying to get them healthy from the inside out. I would also like to say that, there are so many reasons for mistrust. For some people, they're concerned we're trying to, change their beliefs and ideology. While we talk about the COVID-19 vaccine, we had the same level of distrust initially with the HPV vaccine. Many parents thought that we were trying to promote promiscuity, right, and that we wanted their kids to go out and start, being sexually liberated. And I think being able to have those conversations with a trusted pediatrician and say that we just want to prevent your child from developing certain types of cancers unnecessarily, later on in life is what we're intending to do. And we know that, every child will not wait until marriage before they actually, start engaging in sexual behavior. And so in talking to someone, it's important that we dive into their issues. Don't be presumptive. Don't, say it's a one size fit all. And, just really ask them, what are their concerns and talk to them about it in the most transparent and honest way.
Yeah. You have such a great, approach to how you're explaining this, because it makes so much sense and you're just breaking it down. And so we do appreciate you, coming just your stories and how you're explaining this, because you're absolutely right. No one's the same. There's no cookie cutter formula to this. And you mentioned the COVID vaccine, and in relation to that, these communities, the communities who have had this mistrust, is the mistrust of the vaccine itself, what's the reason behind that? Or are they just mistrustful of the healthcare system as a whole? And that's the reason why a lot of, so to say, marginalized communities are reluctant to get the vaccine?
Honestly, I think it's a combination. I think some are distrustful of the system. They're distrustful of the government rollout. But I think others actually are distrustful of vaccine components, right? And they're saying, hey, what is this mRNA vaccine? Where did it come from? How are we able to develop this vaccine so quickly? And I think that created a lot of hesitancy.
And we were talking, and we've been talking with our various guests on our podcast about the very rapid development of all the new medical technology, the vaccines and what have you. And anymore, doctor, you see a whole lot about, some of these folks that are hesitant, that kind of circle the wagon about not wanting to trust a doctor, not wanting to go in. There's more and more about these tele visits, that you pull up on your computer. Heck, I don't know that I can do that. I'm kind of fairly, efficient with things, but that is another barrier that people would say. And in some of these communities, well, I can't get there. I don't have, the way to get there. I don't have anybody that can take me. And like you said, I don't look right. The doctor will just talk down to me. And then I'm being told that I should do the televisits. I can't do them. We need options, doctor.
Right. I completely agree with everything you stated. I think that a lot of people thought that the vaccines did come about too quickly. They were concerned about what was in the vaccines and, this whole, there's been so much advancement when it comes to genetic-based therapies, right? And so now you don't have to give someone a live version of the vaccine. You can use just a simple, strand of that genetic code in order to code for a protein that your immune system will recognize as foreign. So when it sees it in the future, it'll be able to attack. But, I'm a kid. I grew up watching the Jetsons. Mm-hmm. That was like one of my favorite cartoons.
Where are our flying cars?
Right. Uh-huh. There were flying cars. There were smartwatches.
We had Rosie.
Yes, the robot, right? So we had robots in homes, and you were able to have like virtual conversations and talk to people through a screen. Yes. And it was completely inconceivable. I mean, it was something that we thought was just, very visionary and futuristic, but we would never see any of this in our lifetime. And Rosie, right? We have these smart vacuum cleaners at home, and
yes.
And we have smart watches, and we're able to do virtual visits, like you mentioned, where you can look and see someone on a screen who's not in the room with you. And so I would say that, for a lot of people, things have been moving, like lightning in leap years. And I would say that, even though telemedicine is a great tool, right, for those who are tech savvy, those who are able to express themselves. But, a lot of people feel dismissed when they're in the doctor's office. So God forbid, if you have me on a screen, how would you treat me then? And as you mentioned, we all don't have the same nice ambiance in the background. Do you have bookshelves behind you? Do you have trophies and artwork? Or do you live, in a situation where you're cohabitating with, 7 other people in a 2-room apartment, and things are very cramped and disheveled. You may be in a place that's somewhat dilapidated. And will someone look at that environment and judge you and determine what type of care you should get, what, arm of a clinical trial you should be placed in? Are you getting the real vaccine? I mean, it's sad, but I had so many phone calls and questions about that. People would say, Doc, I want the real vaccine. I want what, President Trump had. I want what, Oprah had. Give me what Kim Kardashian had. I don't want that other stuff, because they really felt that there was a tiered approach to not only vaccine rollout, but the quality that, that's given. And the reality is that many people go to safety net hospitals, right? They are underinsured, uninsured. And so they're not going to these, premier private, hospitals, that smell like pine sol. They're going to places that have limited workforce. They don't have a lot of innovation. They're struggling just to serve the populations that they serve. And so they realize that there are inequities. I mean, people aren't blind. And so, it's a valid concern that maybe using certain technologies or using certain drugs may be a disadvantage for them.
You mentioned, the fear of being judged. That's a hesitation for some people in certain communities as to why they don't visit the doctor, or one reason why they may not have a primary physician. What are some other reasons behind that, even with there being greater access than ever before?
Right. So as I mentioned previously, I think that we're creatures of habit. So I think some people, just have not become accustomed to frequent doctor visits. I think there's also implicit bias, right? So occasionally, I'm driving and, I may see an older person, in front of me, and I'm like, oh, it's going to take forever for them, to push the gas pedal once the light change. But occasionally, this person peels out. Or if I see a Ferrari that's driving next to me and I look over, I'm like, oh my God, I never expected, to see this, wise looking woman in here. I think that that's a car that I associate with youth. So I think there is a degree of implicit bias that we all have. I think it's also, people normally prioritize what's important to them. And, we sometimes bring the car to the dealership when the engine is gone. You're supposed to get the oil change. You're supposed to get the tune-ups. You're not supposed to wait to the last minute. But people have other priorities. And if that priority, if they are a wage worker, if they're considered to be an unskilled employee, they may be afraid if they take the time to go to the doctor's office that they may lose their job, right? We only think about the visit. Let's say if it's a 20-minute visit. How long does it take them to get there if they're taking public transportation? If they have to take and drop the kids off at the nursery and then take a bus to the opposite side of town and then spend money trying to Uber to get to work on time, the cost of the Uber may be what they make as a day's wage. So they may not choose to engage with the healthcare system unless it's absolutely necessary and critical. And to speak to that point about engaging with the healthcare system, even I in this role have been short-sighted. A number of our residents in the region are homebound. And so we thought if we can just get a vaccinator, a provider to go to the house to provide them with the vaccine, that will, help to inoculate this particular sector of the population. So I had a caller that called and she said, I want someone, to come out to my house. And I said, yes, ma'am. And I interrupted her. And she was like, no. I need to ensure that they don't come in a medical vehicle or ambulance because I live by myself. And I'm afraid that someone will come into my house realizing that I'm vulnerable, that they will come in and burglarize me or either assault me. So I need for someone to come in a regular car so my neighbors won't know that I'm vulnerable. And how do you address that? Because that's something, it's the sigh. It's like, how do you deal with that? And because a person doesn't even feel safe in their own community because they're old and, they have a disability. And they know that if others people see that, they won't have pity or empathy. They'll see it as a weakness.
And want to take advantage of that.
Yeah. Mm-hmm. So there's so many issues, right? And that's why we have to deal with people, as people, as an individual, and see them for who they are. And, and even I thought I knew what the issue was. Like, yeah, we'll get someone to come out to you. And she was like, no, that's part of it, but I need for them to be inconspicuous because if people see this medical vehicle, it may make me proud to victimization.
And we have to meet people where they are. That's exactly what you've been saying. And that's how we start with the medical mistrust, gradually just kind of chip away at that, doctor, just chip away and then get them into the frame of mind that I can do this. I need to do this for me, for my family, as an example, and for my community. But sometimes it's got to be quiet and it takes a few steps and it might not happen immediately, but at least it starts to happen. And it starts with the conversation like you had with the lady who was so concerned. We wouldn't even think of that, nor did you.
Exactly. And, it's just having the one-on-one conversations. And unfortunately, medicine is a business. Office visits have been shortened. The turnaround time, there's a push for that to get patients as quickly in and out. And so instead of seeing them, the whole person, and addressing, the social and psychological issues that they face and the toll that it has on their health, oftentimes we're only treating a particular condition or disease, and it's unfortunate. So I'm hopeful that this pandemic has unveiled, festering, long inequities that have existed in our society. And now, because they've become so visible and we realize the impact, that we're going to catch the wave, that we are going to actually be motivated. And this is going to serve as a catalyst for us to make the change that's necessary.
Yeah, necessary change, and the work is starting now. And there are doctors like you who are leading the charge to make that happen. And Dr. Hebert-Magee, such an incredible conversation. I know we've learned a lot from you. So thank you so much for your time and your insight. And you've really opened my eyes to a lot of things and how to, be more gentle with people.
Good word. Yes. To be more gentle.
And, just a simple conversation you never know where it could lead. It could lead to helping someone, no matter how big or small that assistance is needed. You just never know. Just talking to people, it goes a long way. I guess because I like to talk. So here we are.
No, thank you for having me. And I would say thank you for asking these very provocative questions, because sometimes people feel uncomfortable having these discussions, but the only way that we'll be able to move the needle and address the issues is discuss what the issues are. So I appreciate both of you for having me today and allowing me to be a part of your platform.
Yes, let's move that needle together.
Yes,
all
indeed.
Of us. Yeah,
thank you.
Thank you so much.
Let's move it into the arm. Let's move it into the arm.
Right. Thank you so much, Dr. Hebert-Magee. And to our listeners, thank you for joining us as well. And we hope you enjoyed today's podcast. Until next time.